Okay, and I'll leave it to you, Peter.
Thank you so much. Thanks for inviting me. Yeah, so let's see, I moved to Peterborough in 2010 to work at PARN, the Community AIDS Resource Network. Prior to that, most of my career has been in population health, community development, mostly in HIV/AIDS and harm reduction. But in 2015, I was asked to become the first community development and engagement coordinator for the Peterborough Police Service. So it's a civilian position. And there I was, part of my role included chairing the Peterborough Drug Strategy, as well as coordinating the risk-driven situation table, the Peterborough one. And then in, I guess about a year and a half ago, I left that role and now am a project lead with the Peterborough Drug Strategy. So happy to come and give this kind of big overview. I'm gonna just share screen and see how that goes. Hopefully everyone can see that. Let me just, okay. So great land acknowledgement. I don't need to do another one. I would just add that for me personally, when I think about being in right relations and the work of harm reduction, that I'm constantly called to think about what it's like to live on stolen land and centuries of colonialism and racism, and how that impacts the work that we do and how it contributes to the trauma that people experience that we're trying to support and serve. I also like to start with a thank you slide. The work that people do is hard. I don't think there's any way to sugarcoat that. And it's gotten harder through COVID. And I think we should be acknowledging that. And so I want to thank you for the work that you're doing. I want to thank you for showing up for other people. And I'd like to thank you for showing up today for this presentation. If I'm going to try to get through a lot of material in about 20 minutes and then have time for questions at the end. But if something comes up that is unclear or you need clarification, please stop me. Use the raise your hand feature, or maybe Sarah can help monitor the chat feature if something comes up. If you're afraid you're going to forget a question and you want to pop it into the chat feature that we can come back to it, that's also great. And you're welcome to contact me in the future if you think of questions afterwards or we don't get to all the questions in this presentation. Any questions before we start? Okay. So as I said, high-level presentation, introduce you just briefly to PDS, just to help give you some context for the other moving parts I'm going to talk about. I'll give you links to find additional information and insight into making referrals and supporting clients to access some of the services we're going to talk about. The Peterborough Drug Strategy is built on almost 25 years of collaboration. PDS has been around for about 12 years, but before that, there was what was called the 4-County Harm Reduction Coalition, and that coalition contributed to the evidence that saw Peterborough get its first needle exchange program, and then we've just been building on those sorts of things over time. There are about 16 partners involved with the Peterborough Drug Strategy. Most of them are represented here. I think one of the ones that I noticed just a few minutes ago that was missing is Nogojiwanong Friendship Center. But basically, through the drug strategy, it's an opportunity for people to look for collaborative opportunities to address the harms related to substance use. If anybody is interested in becoming a member of the drug strategy and you're not already, Jessica Penner is the PDS coordinator and would be happy to send you an orientation kit to give you more information to help you make an informed decision about joining. some of the past projects that we've worked on. And just to be clear, the drug strategy is very much project funded. So we get, I'll use air quotes to say core funding that works out to about 2 days a week to support our coordinator. All the other funding that drives any of the activities we do, that supports my role, that pays for Jessica's role, that all comes through various projects. And then we have the fun of cobbling together all that funding to try and make us look like a reputable organization with full-time staff, as I'm sure you're all familiar with how that plays out. We were I think we were the second hospital to have a naloxone distribution program through our emergency department. We have the Peterborough Regional Overdose Preparedness, which has that group continues to drive the distribution of naloxone. We support a consumer advisory panel, and we're very involved in the advocacy and application process up to getting a CTS started locally. Some of the current projects, A Question of Care, which I hope you're all on that mailing list, provides ongoing multi-sector collaborative training for improved response to the kinds of services we try to provide. The Mobile Support Overdose Resource Team, which I'm going to talk a little bit more about later on, the MSORT team. We continue to support a consumer advisory panel. So if you were looking at launching a new program, you were revising policy, you were looking to develop some initiative, and you wanted input from people with lived experience of substance use and addictions and navigating the systems, we pay the panel to be available as a resource to community partners. So that's something that you could contact me for if you wanted to make a presentation to get feedback on something that you were working on. One of the other projects that's part of my portfolio right now is the Home or Housing Unit Takeover Project. And our website is an ongoing project to provide people with resources. Our Peterborough drug strategy was also fundamental in helping to create the Drug Strategy Network of Ontario. I can't quite remember. I think there's about 40 now across the province. Okay, so the MSORT team. This is funded through Health Canada's Substance Use and Addictions Program. When we wrote it and applied for the funding, we still didn't know if and when we might get a CTS. So MSORT was designed to function independently of a CTS. But anticipating we'd get one, it was also written and designed to align with and combine with a CTS. And so that's what's happened now that we have a CTS up and open. And the idea for the project emerged out of several community conversations about responding to the opioid overdose drug poisoning crisis in 2019. The project is a collaboration between Forecast Addiction Services, Peterborough Drug Strategy, the Peterborough County City Paramedics, PARN, and the Peterborough Police Service. It's important to note here that I was in the role at the time with the Peterborough Police, and it was the police that had the capacity as a member of the drug strategy to really invest in the writing of the grant, which took it was over 40 hours in total to put that proposal together between community consultations and just all the writing and research. And then it was the Peterborough Police that had the capacity to administer the project, but they're not getting any of the money from the project. So they're providing in-kind support, in-kind coordination from Emily Jones, and in-kind finance support through their finance manager. But all of the money is going to the community-based organizations, Forecast, Paramedics, and PARN. There's a program manager. There are 3 intensive case managers. There's a community-based paramedic, 3 harm reduction specialists, and evaluation and knowledge transfer and exchange roles that are supported through the drug strategy. So the objectives of this are to connect people who have recently experienced an opioid overdose What we thought at the time when we wrote it, what was being identified was that they believed there was one of the unintended outcomes of the naloxone distribution program was that people were administering their own naloxone and then not calling 911 or getting any kind of medical follow-up to their overdoses. And so one of the things that we hoped to address was to try and reach that population in a way to provide them with the care and support that they might need. We are absolutely foster a trauma-informed harm reduction approach in the work and enhance collaboration and interdisciplinary teams. So one of the functions of the program manager is to help with some of the systems navigation pieces and to support case conferencing and collaborative approaches to supporting people. Again, initially, we thought that most of the referrals would be coming from first responders. So in fact, our database, the way that we have that set up, it's a shared system or a system that's aligned with that which is used by paramedics. So paramedics can actually, when they're using their iPads or whatever technology they're using, the application they use allows them to make a referral to MSORT just by clicking on one of the buttons. Police and other first responders can make referrals as well. I'll just show you here that there is information on the PDS website. If you go to the website and you can click on the MSORT banner, it will take you to a number of pages related to what the services are, who you can expect to see on the team. If you've got clients that are interested in a deeper dive in what's going on and they have access to the internet, they could use this. It also has a link to a video that will show you how to make referrals if you're not sure or want to be reminded after this presentation. And I think it's kind of one-stop shopping, but if there's something that you think is missing and you think it needs to be added, please just let us know and we'll do that. So one of the things that I think is important is that if you're getting consent to provide somebody's name and information to MSORT, that's all you're giving consent for. So that the client is not giving consent for MSORT to come in and start making a lot of decisions for them or doing a lot of things. Sometimes that makes people anxious. They are strictly consenting for you to connect them to MSORT, and then anything else that they choose to do with MSORT is absolutely up to them. One of the challenges is that a lot of folks who are interested in connecting with MSORT are either living rough and out in the parks or other places, or where they live is a rooming house, or perhaps in some of the situations you might be supporting clients in, living situations where they don't want other members of that they're living with to know that MSORT is connecting with them. So MSORT is great about meeting people wherever they want to try and meet, but it's helpful if you can provide as much information as possible to make that connection a reality. So, you know, for example, the person goes to one roof Monday to Friday for lunch and usually sits under the oak tree in the northeast corner of the park. Like literally that kind of detail is great and helps us connect with people out in the community. People can refer themselves. And so they can call between Monday to Friday, 9 to 4:30. And if they leave a message, somebody will get back to them within 24 to 48 hours, depending on when they've called. It might be just a few hours, or they might actually get somebody answering the phone. Again, it just sort of depends on when they call and how busy the team is that day. The team is primarily mobile, but as I said before, they are home-based out of 220 Simcoe, which is where the CTS has opened. So that really has become an opioid hub and a response center for people in the community. The team does travel around in a paramedic vehicle for the most part, and the paramedic vehicle has all of the markings of Peterborough County City paramedics, and also has metal signs that have been attached to indicate that it's the MSORT team in that particular paramedic vehicle. But it's helpful, I think, to let people know, again, just clients having a heads up that if they're asking to connect with MSORT and have MSORT come to them, that they may show up in a paramedic vehicle. And if that's going to be problematic, then how can we problem solve around a different way of making that connection? MSORT, again, contact isn't always made on the first attempt, but MSORT is committed to trying to make that connection, and so they will make many multiple attempts to make the connection. And if you've made the referral, if they failed to do that over a number of times, may contact you again to see if you have additional information that might help them make the connection. That first contact could be in person or by phone if you've been able to provide a phone number. The paramedic is the preferred part of that initial contact. Again, given the parameters or the goals of the program, the assumption is that this person is either at risk or has recently experienced an overdose, and that there might be health impacts. And so a health and well-being check is part of what we hope will happen in that first contact with the paramedic. And our harm reduction specialists, peers, people with lived experience, are often part of that first contact and help make the connection and facilitate the client connecting with the rest of the team as needed or requested. One of the goals, as I said before, is everyone on the team acts as a systems navigator, and the goal is to connect people to existing services, as opposed to them becoming part of an ongoing caseload of MSORT. MSORT will keep the client as part of their caseload as they try to help them get connected and more stabilized, if that's their goals. And so somebody could be a client of MSORT just for that one contact. They just wanted an immediate follow-up to an overdose. They want to get a new naloxone kit and harm reduction supplies, and that's it, they're done. Or they could have longer term goals and ambitions, and so they might work with MSORT over a number of weeks or months until MSORT can help make those things happen. We've had some really amazing successes because of the nature of the team, because the community-based paramedic is not tied to having to take people to hospitals. So we've had the paramedic be able to facilitate taking somebody to a treatment facility that they wanted to get into. We've had all sorts of different scenarios play out that have been very successful. As I said, 220 Simcoe has become a real opioid hub, community hub. And both the MSORT team and CTS are housed there. So I think one of the things that I imagine is that it might get a bit confusing for some folks who are navigating the different hours. So again, right now, MSORT is working Monday to Friday, 9:30 to 4. CTS will have expanding hours, and so we'll be expanding beyond that. And there's also community withdrawal management team members from Forecast that are on site, and they have slightly different hours. The harm reduction services in the form of sterile drug using supplies and naloxone are also available through through 220 Simcoe. And again, that's through the ongoing partnership with Peterborough Public Health and PARN. If people want training on naloxone or information on how to be a distributor for naloxone, their best contact is Peterborough Public Health. And the CTS did in fact open on Monday. Hopefully some of you were able to attend one of the open houses that the CTS hosted before they actually opened. But if you didn't, this is sort of a general layout of what was the old Greyhound bus depot. A couple of things that I want to highlight here. First, if you come in that main entrance, on the left of the slide or to your right when you walk in is the harm reduction desk. And so you are welcome to go and drop in there to pick up supplies, but also I was saying, we have these great cards for MSORT contact and information, and there will be CTS cards coming. If we were in person, I'd be handing these out, but we're not. So if you happen to be near 220 Simcoe one day and want to stop in, please stop in and ask for some cards that you can share with your clients if you'd like to do that. Also, when you're looking at this slide, the green area that says client area, there's actually 3 booths there set up for people who want to come and use their drugs on site. And there's always staff there to watch for adverse effects or an overdose, and are prepared to deal with that. I also want to note, in terms of if you have a client that you're encouraging to use the CTS and they've not been there before, you are more than welcome to attend with them. You'll see on the here on the slide, the health consultation room, that the whole point of that room is that is the space where you could come and meet a client, have a conversation about supporting them in their use of the facility, whether it's for the CTS or whether it's picking up harm reduction supplies, or maybe it's somebody that you haven't found another safe location to meet them, but you know that they use the CTS and they can let you know when they might be there. You could arrange to meet them and have a conversation with them there about something else that's related to their care and support. I think that's everything for that slide. The CTS team, it includes paramedics. There's a whole team of paramedics to ensure that they can cover all the various shifts. There's, I think right now it's just 1 registered nurse, but there is a registered nurse to help cover some of the shifts. The harm reduction specialist, which is people with lived experience or peers, and the program manager. You can expect to find a paramedic or a nurse and at least 2 harm reduction specialists on every shift. So this first week that the CTS is open, their goal is to be open from 10 a.m. to 4. Starting on the 20th of June, through the rest of the summer, they will be open from 9:30 until 7:30. And then based on the patterns of use and the feedback from clients, and not just the clients that are using the CTS, but other people that might be coming in for harm reduction supplies but aren't using the CTS, what might work for them if they were going to use the CTS. They'll look at how that informs the hours moving forward. No referral or appointment is necessary. This is a health facility, so at least for the moment, people are still asked to wear masks when they arrive and to do a COVID screener, but there is no mask expectation, especially while you're using. The reality is that the paramedics and the nurse will want to be able to see people's faces in terms of monitoring breathing and looking for some of the signs like blue lips in terms of if people are having an adverse experience. And certainly nobody will be turned away if they showed up without a mask. The goal is to be as accessible as possible. There is drug testing available. So I think right now in the short term, they have the fentanyl strips, but we did make a presentation to the city and were approved for a mass spectrometer, which is being purchased, and staff will be trained on that. So we will be able to do a deep level dive on testing people's substances. It can be a sample from their actual product, or it could be residue from some piece of equipment they've used. So a person doesn't really lose anything of the drug that they've brought in to use, because of course people bring in their own drugs. We're not providing people drugs. And if we find out that a drug is particularly tainted or has all sorts of ingredients that is not what the client thought, the drugs are not confiscated. So the point is that they would then work with the client to say, well, now that we know it has all these different components to it, here's how you might want to think about using. We maybe need to try a smaller amount first, whatever. It's a harm reduction approach. And as I said before, service providers are really encouraged to do a warm handoff. And there is that counseling room so that you can attend with a client and have a conversation, introduce them to CTS staff, and make it as good an experience as possible. Some of the other moving parts broadly in terms of the response to the drug poisoning opioid crisis, the nurse practitioner-led clinic has launched a safe supply project. So Carolyn King is one of the leads for that. They have 50 patient capacity. The process for that is that you can make a referral. I can send along referrals forms along with this presentation if you like, if you don't have those yet. And I think Carolyn said they can onboard 2 to 3 people a week. So the reality is that they have to do it slowly and intentionally and really work with the client in those initial days that they are onboarded. So people might be on the waiting list for a little while they wait for their turn to be onboarded. Mr. Situation Table, hopefully you're all familiar with that. Emily Jones is the coordinator out of the Peterborough Police Service. The RAM Clinic, which is co-located with the nurse practitioner-led clinic, they moved to that new location not too long ago. The eFRI program, a different approach. The Forecast community withdrawal management and other supports. And also the newly launching mobile outreach with a county focus from CMHA continues to evolve in terms of what they hope to accomplish. And if you wanted more information about that, your contact is Jeff Cadence at CMHA. As I said before, I can share the presentation, so these links will all be embedded in that so that you can look them up if you like. I've left the housing unit takeover resource folder that we've created as a link. There's a whole resource manual there and a number of worksheets. They may be useful to you as well. And if you want a separate presentation on home takeovers, I can do that if you want to reach out to me to arrange that. And that's it. So that was a little bit longer than I thought. Sorry about that. But if you have questions or if we have time for discussion, I'll look to Sarah for that cue. Happy to do that.
Were there any questions for Peter?
I do have a question. Peter, you mentioned, I've been down to MSORT and I've seen a client there because they felt more comfortable in that space. So it's been great. You mentioned that the CTS doesn't provide drugs. I saw an email welcoming us to an open house at the 360 for the safer supply. And I'm not aware of what that is. And I know it's not what you're presenting on today, but I'm just curious. And I wasn't able to go to the open house. So just curious the differences between the programs.
So safe supply is a harm reduction strategy to get people on prescription grade drugs that they then can use so that they're not using an unknown street toxic supply. They're funded for a year right now, but they have made arrangements to be able to support clients that want to remain on the program beyond funded project. They just won't be able to expand the project beyond that, but they are looking for additional funding. And as I said, I can include the referral form that will have a little bit more information for you with this presentation. One of the challenges is that there's been a lot of work that's needed to be done with the shelters because some of the shelters have not been as open to the conversation about looking at this as a harm reduction strategy that some people might choose to think about as a pathway to treatments, others will not. But that just to ensure that people aren't ejected from the shelter system because they're choosing to be part of the Safe Supply project.
Thank you. And it's different still from RAM and
yes, so the Safe Supply project is a program of the nurse practitioner-led clinic.
Okay.
The RAM clinic used to be co-housed with Parn at 159 King, but Parn has moved to East City in the old Examiner building. They're on the second floor there over the RBC, and the RAM clinic has moved in so that they share space with the nurse practitioner clinic.
There was a question from Ryan.
Yes, two things. So Tracy, maybe I can get a little bit of insight as I went to the open house yesterday. So it's specific for individuals who are taking opiates, usually fentanyl, and are having medical complications related to their substances. And they have to be willing to take a opiate in front of a pharmacist daily, and then are given Dilaudid for them to use like away from the pharmacy. So I don't know if that helps to clear things up a little bit.
Thanks, Ryan.
And
yes,
then my
thank you.
second question, Peter, maybe you can shed some light on this, and maybe you already answered this because I missed the first 20 minutes of your presentation. My apologies. But it's my understanding that, I mean, a high percentage of fentanyl users currently smoke fentanyl, and the safe injection site isn't currently allowing or equipped for individuals to smoke fentanyl in the building. Is that something that is looking to change, or can you shed some light on that at all?
Yeah, so the main barrier is the Smoke Free Ontario Act, which prevents people from smoking their drugs indoors. The CTS actually, because of the money that was fundraised through the Light the Way campaign, there was enough funding to renovate the building in a way that it could have the capacity to safely, it's ventilated in a way that people could from a safety perspective. But it's the Smoke Free Ontario Act that we're trying to work around, and there's some federal legislation around smoking indoors that was intended to be applied to tobacco, but is now being applied to this. So the Yukon, as far as I know, is the first territory to successfully challenge and get an exemption from the federal government so that people can smoke their drugs inside. And we continue to work on that and apply pressure to the government for that exemption. There's, in terms of the sanctioned CTS, there's nothing right now that supports people to smoke, but you are absolutely correct. The numbers have drastically changed. So when we started to advocate for a CTS, I think it was about 3/4 of the people were injecting, and maybe 1/4 were smoking. And now I would say it's closer to 2/3 are smoking and 1/3 are injecting. So we have to work at that and try to make change fast.
Okay, thank you. Were there any other questions for Peter? Okay. Thank you so much for coming today, Peter. That was super informative.
Yeah, my pleasure, sir. Thanks for the invitation. And I will send this out to you right after the call.